Now let's talk about biliary colic. Biliary colic, it is associated with nausea, vomiting, dull right upper quadrant pain, and neurohormonal activation by CCK after a fatty meal. Triggers contraction of the gallbladder, forcing stone into the cystic duct. Labs are normal. Ultrasound shows cholelithiasis. Okay, so again, this is you have a dull right upper quadrant waxing and waning pain, which is again called biliary colic. Waxing and waning dull right upper quadrant pain. CCK is triggering the contraction of the gallbladder. That is forcing, if you were to contract the gallbladder, if you're contracting here, this guy here, you're forcing the stone to come towards the cystic duct. And here the labs and ultrasound shows cholelithiasis. So cystic duct is the main thing we can think of. A contraction of the stones coming from contraction of the gallbladder pushes the stone into the cystic duct. Right here. Okay, let's talk about cholelithiasis. Okay, this is the presence of gallstones in common bile duct. So for this thing, let me just draw the normal so that you can see. Let's just draw it here. So you have a liver and you have the gallbladder. From the gallbladder you have this cystic duct and this the hepatic ducts, they join together and they form the common bile duct. Common bile duct. And that common bile duct eventually joins with the main pancreatic duct. And gets out in the second part of duodenum. Okay, so we did talk about the cystic duct causes biliary colic. Now cholelithiasis, in which you have the gallstone in the common bile duct. Which is the common bile duct? Right here. Common bile duct. Okay, common bile duct, often leading to elevated ALP, GGT, direct bilirubin, and or AST/ALT, because you're also damaging or blocking the liver, right? That leads to, you will have a high increase in these things, but so you have a way too high increase than the AST and ALT. Now let's talk about the other thing now. Cholecystitis, gallbladder cystitis inflammation, acute or chronic inflammation of the gallbladder. So you have the cholecystitis, most common type. It is due to gallstone impacting the cystic duct. Right here, you have impacted on the cystic duct, resulting in the inflammation in the gallbladder wall thickening. Looking at arrows in B. Well, you can't see an image here, but there's a thickening of the wall of the gallbladder. So this is the gallbladder, that there's a thickening of the wall of the gallbladder. Can produce secondary infection. Okay, can produce secondary infection. Now, second thing is acalculous cholecystitis. It is due to gallbladder stasis, hypoperfusion, infection seen in critically ill patients. So again, one thing, it's pretty simple for looking forward here. Look in this picture. If there is a stone blocking here, you have inflammation. Anytime you block a tube, behind that you got inflammation. You have inflammation, there's a wall thickening. That's calculus, meaning stone being present there. Acalculus, cholecystitis, meaning you don't have the stone, but either you have a decrease in blood supply, which is basically hypoperfusion, or you have the stasis of the gallbladder due to any cause, or you have infection, see a reinfection seen in the critically ill patient that causes inflammation of the gallbladder without stone presence. Okay, so let's talk about Murphy sign. Murphy sign is inspiratory arrest on right upper quadrant palpation. So as soon as you're doing a right upper quadrant palpation, there's an inspiratory arrest due to extreme pain. Pain may radiate to the right shoulder due to irritation of the phrenic nerve. Increase in ALP if bile duct becomes involved. So right here we're just thinking about the gallbladder itself, right? So but they're saying if the bile duct gets involved, then you are looking at increase in ALP, and that would be called an acute cholangitis, which is going to come here. You can diagnose this with an ultrasound or a HIDA scan, cholecystography. Failure to visualize the gallbladder on HIDA scan suggests obstruction. If you cannot see the gallbladder on HIDA scan, then it suggests obstruction. Now let's talk about gallstone ileus. If you have a fistula between the gallbladder and the GI tract, this is your gallbladder and this is your GI tract. So stone from here enters the GI tract, obstructs, but from duodenum it goes all the way to the ileocecal junction. It obstructs at the ileocecal junction now, and because that's the narrowest point is the ileocecal junction. So now, because it's obstructed here, now you will see biliary air in the biliary tree, pneumobilia, and regular triad. What is that? Radiographic finding of the pneumobilia. Small bowel. So this is also going to cause small bowel obstruction, sign symptoms, and the gallstone in the iliac fossa. So the gallstone here, you have these small bowel obstruction signs and symptoms, and you have the pneumobilia. Right? When this obstructed, this formed fistula, the air also went down into the gallbladder, causing pneumobilia in the bile ducts, and you can see air there. So it's a pneumobilia. So that's with the cholecystitis, inflammation of the gallbladder, but in the gallstone ileus. Gallstone ileus means you're blocking you're blocking the way out and not letting the contraction move forward. Okay. So now let's talk about what do we have here? The porcelain gallbladder. This is a calcified. Looking at the picture, you can really see the calcification, but let's just read. Calcified gallbladder due to chronic cholecystitis, usually found incidentally on imaging. Again, it's a calcified gallbladder. Why? Because of chronic cholecystitis. Chronic inflammation of the gallbladder leads to calcification of that gallbladder, and you can see it on imaging, an incidental finding. Treatment is prophylactic cholecystectomy. Take that out prophylactically. Generally it is recommended due to increased risk of cancer, mostly you have the adenocarcinoma. So same simple thing, chronic cholecystitis, inflammation of the gallbladder, can cause the calcification, calcium deposition into the gallbladder, which is called calcified gallbladder, which can be seen on the imaging. And you don't want to keep it there because it can lead to formation of cancer. Okay. And on the picture would show you thickened gallbladder wall with the rim of calcification. Okay. Why would it occur? Well, it occurred due to dystrophic deposition of calcium salts. Due to in the setting of chronic infection. Inflammation. Okay, now let's talk about acute cholangitis. Acute cholangitis, that's also called ascending cholangitis. It is infection of the biliary tree, usually due to obstruction that leads to stasis, bacterial overgrowth. Okay. You have the Charcot triad of cholangitis includes, what is the triad? You have the jaundice, fever, right upper quadrant pain. It's called the Charcot triad. Jaundice, fever, and right upper quadrant pain. Something else, it's a life-threatening infection. Okay. Or you could also have a Raynaud's pentad. First of all, you have this Charcot plus altered mental status and shock. Okay. If you were to do imaging here for acute cholangitis, you will see biliary dilation. And all you have is, like, in acute, you have ascending cholangitis, infection of the biliary tree. Why would you have an infection? Because of the obstruction that led to stasis or bacterial overgrowth that caused the infection, and infection is now going up and up. Ascending cholangitis. You can have a Charcot triad in which you have jaundice, fever because of jaundice, jaundice, fever, right away, infection, fever, jaundice, and right upper quadrant pain. But on the pentad, you can have the Raynaud's pentad with altered mental status and shock. Okay. So that's pretty much all we have for this guy. One thing, yeah. Now I think the last point in the biliary, we have the cholangiocarcinoma. Cholangiocarcinoma, it's a malignant tumor of the bile duct epithelium. Most common location is the convergence of the right and left hepatic ducts. At the convergence of left and right hepatic ducts. Risk factors include, so that's how they can explain that there's a mass at the convergence or the joining of the right and left hepatic ducts. Okay. Risk factors include primary sclerosing cholangitis, liver fluke infection, usually presents late with fatigue, weight loss, abdominal pain, jaundice. Imaging shows biliary tract obstruction. Histology is infiltrating neoplastic area, neoplastic glands associated with desmoplastic stroma. So the mass of glands present at the convergence of intra and extrahepatic ducts. That is cholangiocarcinoma. Okay, that's pretty much all we have for cholangiocarcinoma.